Good evening and welcome to Northwell's Rehabilitation Lecture Series. This is Tom Phillips, Senior Director for Northwell's Physical Medicine and Rehabilitation Service Line. Let's quickly go over some of the session specific information. In order to be eligible to receive CEUs, you must be logged into this session with your full name and credentials. You must be registered for this event through Eventbrite, and you must attend the session in its entirety. Please make sure that your microphones are muted and your cameras are turned off. Please use the chat feature in Zoom to ask any questions you may have, and our faculty will answer them via chat. If you have questions after the webinar, please email them to us at rehabeducation@northwell.edu. Please note that you will receive your certificate of completion within the next 10 business days. As always, please share your feedback with us through the survey that will be emailed to you all. In tonight's session two of this two-session series, we will further discuss speech-language pathology management of a patient with lung cancer. Let me introduce tonight's presenters to you all. Dr. Joshua Benjamin Silverman is an associate professor of medicine at Donald and Barbara Zucker School of Medicine at Hofstra Northwell and the chief for the Division of Laryngology at Northwell's Long Island Jewish Medical Center. Kristen Bill is the director of clinical services speech-language pathology at Northwell Health Long Island Jewish Medical Center. Rebecca Spern is a registered dietitian for the Department of Radiation Oncology at Northwell's Monter Center for Cancer.
Good evening. First, I'd like to thank you very much for the opportunity to speak about the larynx and its role in the management of lung cancer. And in particular, I'd like to thank Kristen for the invitation. In a recent study out of Johns Hopkins, in a cohort of lung cancer patients, it was found that more than 50% suffered from significant dysphonia. And so it's important that we be asking about the voice and swallowing in lung cancer patients. And tonight I thought we would talk about some of the anatomy of the larynx and why there are changes with the vocal folds so frequently in lung cancer patients and some of the management that we do to help the voice and the swallowing, as well as the breathing. I have no disclosures. So when we think of the larynx, basically there are three main functions that make this organ so vital. In particular, it is a breathing passageway that allows air in and out of the trachea and then into the lungs. And when blocked, obviously causes airway obstruction, which can be life-threatening. In addition, it acts as a complicated valve or sphincter that allows swallowing to occur normally and allows the food bolus to pass into the esophagus, and if not, can cause aspiration, and also provides for the successful swallowing or when negatively affected, the significant dysphagia that we see with so many of our patients. And finally, in the interaction between the vocal folds, it allows for voice. And when there's a problem with either the motion of the vocal fold or the structure of the vocal fold, either one or both, then we get dysphonia or even aphonia. When the etiology of unilateral vocal fold immobility was assessed a few years ago, it was seen that about 13% or more than 10% of cases were due to malignancy, and the vast majority of these were from lung cancer patients. The anatomy of the larynx is created by a series of cartilages and muscles that sit within and surrounding the pharynx. And although the larynx is an internal organ, the advancement of the flexible laryngoscope has allowed for even subtle changes in vocal fold motion and structure to be seen easily in the office. And so over time, our ability to assess even subtle changes in the motion of one or both of the vocal cords um, has really greatly allowed for earlier diagnosis uh, of pathology, and has also allowed for awake procedures to be performed uh, either for um, vocal cord paralysis patients or biopsies or um, other voice disorders. And so this has really allowed the field to advance rapidly. The key to motion of the vocal folds relies on the arytenoid cartilages, which sit atop the cricoid cartilage and rock in 3 dimensions to allow for abduction and adduction of the vocal folds. Most of the muscles act to adduct or close the vocal folds as the primary function of the larynx is to prevent aspiration. But what makes the organ so unique is that it's also the abduction or the opening that allows for multiple functions from the same structure. When we look endoscopically uh, in the office or in the operating room, we can fully assess for motion, and the addition of the stroboscope to the laryngoscope uh, equipment has allowed for individual waveforms from the vocal folds to be studied. This is an example of a patient with normal bilateral vocal fold motion. What we can see is that during phonation, there is adduction of the vocal folds and complete closure between them, creating a regular and patterned wave. It is this wave that allows for clarity of voice, and the the lungs are the power to the system. And so any change in this system will result in dysphonia. The reason that the laryngeal functions can be so affected by lung cancer is that the primary innervation to the laryngeal musculature is through the recurrent laryngeal nerve, which on each side reaches off of the vagus down into the mediastinum before recurring or coming back up the neck to innervate the larynx. And so there's actually many ways that that a pulmonary tumor can affect the nerve and cause dysphonia. The tumor itself can grow and cause stretching of the tissues and thus stretching of the nerve, or it can directly invade the nerve and cause dysfunction, or it can spread to lymph nodes nearby, which can also cause problems. And then also in when there is thoracotomy or there are procedures done to um, remove the lung cancer, this can also obviously affect the recurrent laryngeal nerve and thus cause vocal fold immobility. Or even intubation during the procedures can cause problems with the nerve. So once we identify the paralysis, then it's important to subsequently identify what is the true cause of the immobility. So, as we were saying before, dysphonia can come either from changes within the vocal folds or due to lack of mobility of one or both of the vocal folds. And it's really important to determine the cause, as it could be telling us that there's a life-threatening condition going on, in addition to the significant impact on the quality of life. In taking a history for dysphonia, it's important to not only assess the voice quality as well as volume and vocal fatigue. If there are periods where the patient loses voice completely, if there is pain when speaking or swallowing, and the onset of the voice change as well. I frequently use the mnemonic grabs to remind me of the voice assessment in terms of grade, the roughness or raspiness, the asthenia, the breathiness, and how strained the patient is. And this is important to differentiate from hypo or hypernasality, which can also cause voice change, but is not coming necessarily directly from the vocal folds themselves. Or is this a speech problem, such as a stroke patient who is dysarthric? Essentially, when we discuss vocal fold immobility, that falls into the category of glottic insufficiency, which can have a number of different causes. But for the purposes of today's discussion, we are really mostly concerned with the neoplastic causes of immobility. So if we look at a particular patient interaction that is somewhat typical in my office, um, this was a few years ago. I saw a 74-year-old gentleman with a 6-month history of worsening dysphonia, and he described the problem as increasingly unable to be heard or understood. And he noted that the more he talks, the more winded he becomes. In addition, he described frequent coughing with thin liquids. And on a swallow study, there was aspiration with both nectar thick and thins. And in my assessment of the voice, he was severely asthenic and breathy. When we looked in at the stroboscopy and laryngoscopy in the office, it became clear that there was glottic insufficiency due to left vocal fold immobility. And what we can see in this video, the right vocal fold is trying its best to compensate and even crosses midline, but even still, because of the lateralized position of the left vocal fold, there continues to be a persistent glottic gap. And it's through that gap that aspiration occurs, as well as causing the severe dysphonia. So we then obtain neck and chest CTs for this patient, and there was, in fact, a spiculated left upper lobe mass found consistent with a lung cancer that obviously requires treatment unto itself, but we also need to determine management for the vocal fold immobility, as he was at great risk for aspiration. So in general, the treatments for a paralyzed vocal cord can be placed into three categories. There's injection laryngoplasty, laryngeal reinnervation, or a laryngeal framework surgery. All of these treatment modalities are meant to uh, move the affected side to the midline, and in the reinnervation case, this is using a nerve in the neck, usually ansa cervicalis, which is working to reinnervate the larynx and provide tone and some function on that side. The injection and the framework surgery, which is also called a thyroplasty, provides static medialization of the vocal fold. This is an example of a patient who actually had bilateral injection laryngoplasty, and this can be done in the office with a filler material similar to wrinkle fillers that are commonly used in plastic surgery offices to augment the vocal folds and move them towards the midline so that they can touch each other and produce voice. And the great advantage, as mentioned in this procedure, we can do this awake in the office, and the patient typically will walk out 15 or 20 minutes later with significantly improved voice. The downside to the injection is that it typically is temporary, not always, but usually lasts between 6 and 12 months and may need to be repeated. In the case of thyroplasty, we actually medialize the vocal fold with a permanent implant. And so this is a procedure that's done in the operating room, as it is an open neck procedure, but the patient's actually awake and just mildly sedated during the procedure because I want to hear his or her voice as I put different sizes of the implant in to determine the most appropriate size. This is an example of a patient after the thyroplasty, and you can see that the left vocal fold is still immobile, but is now in the midline and can easily contact the mobile right vocal fold and create glottic closure. So this not only greatly increases the voice, but it also significantly improves swallowing. I would like to thank you very much for your attention. And I apologize that the nature of the recording makes makes for some maybe awkward moments, but thanks for bearing with me.
Good evening, everyone. My name is Kristen Beadle, and tonight I will be discussing with you voice evaluations and interventions for patients with lung cancer. The objectives for this lecture are to describe phonation and voice disorders, describe the impact of lung cancer on phonation, and discuss evaluation and interventions for dysphonia in lung cancer patients. So first, let's define what is a voice disorder. So a voice disorder can be defined as a time when voice quality, pitch, and loudness differs or is inappropriate for an individual's age, gender, cultural background, or geographic location. It's also present when an individual expresses concern about an abnormal voice that does not meet their daily needs. We know as speech pathologists, we often encounter patients with an irregular vibratory pattern, and we know that further assessment is warranted. So now let's just take a look at dysphonia and the impact on quality of life. So we know that voice is an important part of human communication. And when there's a disruption, it can impact the patient's social life, their employment, their relationships, their overall self-confidence. At our center, we often give patients with a voice disorder the Voice Handicap Index. And what that is a patient questionnaire that will rate how a patient feels their voice disturbance is impacting them on a daily basis. And oftentimes we find that these patients are feeling as if they have a handicap, and that they're not able to really communicate the way they'd like to. And that can really be, it's something that's very, very upsetting to patients, especially those who are already dealing with the stress of cancer treatment and a cancer diagnosis. So just take a little bit more look at the psychosocial impact. I know I had just discussed the Voice Handicap Index. And again, this is a quality of life instrument. It can evaluate how a patient feels, their voice and vocal issues are impacting them. And this can include social impact, economic, environmental disadvantage. And again, they may feel like they're impaired and have a disability. And just to give you some details, it's pretty easy to administer. It's 30 questions with a 5 point rating scale that the patient will rate how they feel. So, zero being they never feel a certain way, and five that they feel that way all the time. And then you measure it and you can get a rating on how much a patient's voice disorder is impacting them. So now let's just take a look at the phonation cycle. Let's just review how the voice works. So let's start with investigating how vocal folds vibrate and produce sound. So the vocal folds generate a rapid series of pulses which allow air to exit and excite the supralaryngeal air column in order to produce a complex tone. We know that there is a myoelastic aerodynamic theory of phonation. And to really break this down, we can just discuss it in different parts. So the vocal folds are activated by the airstream from the lungs. And the theory is a description of the interplay of the physical forces of aerodynamics and the elastic tissue forces of the larynx, which is really important when we think about lung cancer patients. Myoelastic refers to the ways in which muscles, myo, change their elasticity and tension to affect changes in frequency of vibration. And then the number of times the vocal folds open and close per second is the frequency of vibration. So there's a lot of different parts and different areas to consider when we think about how voice is produced. So here in this slide, we're just going over a basic review of the systems of speech. So that includes respiration, phonation, resonance, and articulation. For the purposes of this lecture, and given the focus on lung cancer, we will be discussing mostly the respiration and phonation components of the systems of speech. So now let's take a look at respiration. So we do know that our lungs are our power source. That is what's giving us volume and good endurance when we're voicing. So if we break this down and discuss first inhalation, well, what happens during inhalation? Well, the rib cage wall expands, the diaphragm contracts and descends, lung air pressure lowers, and the outside air rushes in. So it's really important that we also keep in mind the strength of the diaphragm in our patients that we're working with. So now if we take a look at exhalation, what happens during our exhalation? Well, the diaphragm then relaxes, the volume of thoracic cavity decreases, and the pressure from within increases. So now let's just briefly review lung cancer treatments that a patient may be discussing with their medical team and reviewing their options depending on cancer staging and also the progression of disease. So we have surgical resections, radiation therapy, chemotherapy, and these could be done either in combination or a patient may just have one treatment as part of their plan initially. So, as we know, lung cancer treatments do have side effects. They could be acute or they could be more long term. And some of those include fatigue, weight loss, respiratory issues, coughing, shortness of breath, heartburn, reflux, or LPR. So, if we take a look at this list and we're just thinking ahead, like speech pathologists, in terms of voicing, we can see that many of those can contribute to dysphonia and vocal disorders. So, if we take a look at fatigue, that may influence a patient's phonation time or endurance. Respiratory issues are another red flag as it relates to dysphonia. There might be some issues with coordination between phonation and respiration. Again, that might be resulting in reduced phonation time, increased shortness of breath when speaking, and fatigue as well. But also, if we look at coughing, um, that again can be traumatic to the laryngeal muscles. It can cause irritation and swelling, which can interrupt the vibratory pattern and mucosal wave, and then influence the sound of the voice. Shortness of breath, again, that can influence the ability for patients to produce a loud voice, with our lungs being our power source. And then we have heartburn and reflux, which can engage patients with increased throat clearing, complaints of globus sensation, and that can also result in swelling and edema um, in the laryngeal structures that can again interrupt the vibratory pattern. So now let's just take a little bit more of a look at voice disorders in patients with lung cancer. So it's not unusual for hoarseness or dysphonia to be a common symptom of lung cancer. This can be a result of the recurrent laryngeal nerve having some sort of weakness or injury. Lung tumors can press on the nerve, causing hoarseness. More common in those with tumors in the left lung. But the recurrent laryngeal nerve, as we know, is an important nerve that supplies the larynx. So, weaknesses to the nerve can cause dysfunction in vocal cord vibration with the inability for vocal cords to close completely. As speech pathologists, we may get referrals for patients with a hoarse voice or with a concern for aspiration. So we may be the first people to really identify the disruption in vibratory patterns just with a perceptual exam, just by listening to the patients talk to us. So we could really be the first people to initiate the steps in the assessment medically. So just as a review, when it comes to the recurrent laryngeal nerve, we know that the recurrent laryngeal nerve innervates all intrinsic muscles of the larynx except for the cricothyroid. The right side of the nerve descends in the neck to loop around the subclavian artery and then ascends alongside the trachea. The left side descends into the thorax, loops around the aorta, and then ascends alongside the trachea. So here in this image, we are focusing on the anatomical structure of the recurrent laryngeal nerve. It illustrates both the right and left side and the proximity to the larynx as it descends and ascends through the chest. So now let's just take a little bit more of a look in vocal quality. This is the perceptual description of voice. So this is how you may describe a patient's voice as you engage in low-level conversation. You might describe the voice as hoarse or breathy, where you're hearing some audible escape from the of air during phonation, which is not uncommon when patients have a glottal insufficiency or a glottal gap. Also tension. So patients are really pushing to produce voice and they become tense when speaking. So again, all of these are things that you may hear when you are getting that perceptual analysis with your patients. Now let's discuss major symptoms. And these are things that your patients, when you're doing your intake, may report to you. They might give you some sense of what they think their voice sounds like. But some of those symptoms include hoarseness, vocal fatigue, breathiness, reduced pitch range, aphonia, which can also come and go, and also pitch breaks while they're speaking. Patients may also describe their voice as being strained or feeling like they sound strangled, and this could be consistent with difficulty getting voice started and maintaining voice. They may feel that they're straining to talk, and they may have a tension when speaking, and that can result in fatigue. Not as common in lung cancer patients, but just something to be aware of when we are evaluating and assessing patient's vocal quality is tremor, okay, which is like a wobbly or shaky sound to the voice. But pain with respect to cancer patients and other physical sensation can certainly be something that we hear, again, while we're working with our patients. It could be unilateral. It could be pain that varies through the neck or throat. They can have sensations of globus. As we know, patients who are undergoing cancer treatments may have increased dryness And again, that frequent coughing or throat clearing, which can be influencing vibratory patterns and the way voice sounds. So now let's talk about loudness. And as we mentioned in earlier slides, it's not unusual for a patient with lung cancer to report changes to their voice, and one of them being the ability to project their voice, particularly in a loud environment. They may have complaints that people can't hear them or they're straining to produce voice. And as we mentioned, our lungs are our power source. That's what's giving us our intensity. So when we talk about loudness, that's the perceptual correlate of intensity. And patients who have issues with that projection or with that ability to produce a loud voice, they may have what we would describe as a monoloudness, which is an inability to voluntarily vary the loudness. It might be a variation, or they could have reduced loudness range, which could also be concomitant with a low pitch range, and they have a difficulty with those loud voice productions. This could also lead to strain, okay, or fatigue. So now let's talk about pitch. So pitch is the perceptual correlate of fundamental frequency, and this is how high or low we perceive somebody's voice to sound. And it's related to how quickly the vocal cords can vibrate during phonation. So, obviously, if we have a patient that has an immobility to a vocal cord or a vocal cord paresis or paralysis, pitch will be affected. So, if we think again about our lung cancer patients, not only will they have a potential reduction in their power source at the level of the diaphragm or in their lungs, but they also, because of damage to the recurrent laryngeal nerve, may have an inability to move those vocal folds in a way that gives them adequate pitch. They may demonstrate or experience a pitch, which would influence the inflectional variation. It could result in pitch breaks where uncontrolled sudden shifts of pitch can be observed. It could be unacceptable for age or gender, where they go too high or too low because they are hyperfunctioning. Or there could be a reduced pitch range, where they're not able to produce high pitch without effort. So, as speech pathologists, another area that we want to look at, specifically when we're working with patients with lung cancer and who are having difficulty with their voice, is phonation time. So, we know that phonation time is the maximum time a person can sustain a tone in one breath. When we recognize that a patient has compromised phonation time, it's telling us that there's a breakdown in the respiratory system and or the inefficiency of the phonatory system. So again, it's going back to the issues between vocal cord movement and the diaphragm and the lung cancer patients that we're discussing and working with. So here we have listed some norms. So this is the amount of time that males and females and children should be able to hold that sustained phonation prior to their voice, what they would maybe describe as giving out or getting tired. So patients with lung cancer who do demonstrate reduced phonation time, you may see some, shortness of breath when they're speaking. They may also report to you that they get tired when they are talking, or that their voice gets weaker as they're talking, and that their ability to project and speak over a long period of time can be compromised. Now, there are different methods of investigating acoustic signs, really breaking down and getting instrumental assessments and evaluations of patients with dysphonia, and getting measurements with respect to pitch and loudness as it relates to hertz and decibels. And we can do that with different instrumentation, such as a Visi pitch. Or the computerized speech lab, both developed and manufactured by Pentax Medical. And again, we could get those standardizations and be able to really get good measurements on patients' voice. However, these aren't always available to all of our clinicians, depending on the centers that they're working in. So there are other ways to evaluate and get information on a patient's vibratory pattern, despite having these devices present. So, two types of non-instrumental assessments that are available specifically for aerodynamics are the maximum phonation time, which we just discussed in a previous slide, and the SZ ratio. So, when we talk about the maximum phonation time, you can simply ask a patient to sustain an off at a comfortable pitch and loudness. This again will measure respiratory function, laryngeal efficiency, and also the patient's ability to coordinate respiration and laryngeal functions. And really, all you need is a stopwatch. So it is something that's easily put into place during a session. The other, as I mentioned, is the SZ ratio. So it's the patient's asked to sustain an S and a Z at a comfortable pitch and loudness. And the purpose of this is to assess the effects of pathological conditions on phonation, and you may be able to distinguish a problem with the respiratory function and laryngeal efficiency. So it will be, comparing two sounds, voiced and voiceless, to see what the differences are. And we could get a little more information based off of that exam. To look a little further into the SZ ratio, you can also measure the phonation time and the maximum phonation time of S divided by the maximum phonation of Z. The normal ratio should be 1 given the placement of the phonemes. But the reduced sustained phonation of Z is suggestive of a compromised vibratory behavior or incomplete glottic closure. So as we mentioned before, we may be the first people to determine or perceptually distinguish a change in a patient's voice. And these are, again, simple techniques that can be implemented to give us more information about that and to see if there is a need for additional medical workup. So now that we have given some attention to respiration and phonation and how it impacts patients with lung cancer, let's discuss some treatments and some interventions that may be beneficial to these patients. So first, let's discuss abdominal breathing. So this could be used to address hyperfunction. As we mentioned before, these patients might be really straining and struggling, increasing their medial compression to produce voice. It can lead to strained voice and again, that reduced breath support. So the technique is asking the patient to breathe in and out, allowing the abdomen to expand on inhalation and move in on exhalation. So sometimes this cue of asking the patient to place their hand on their chest or on their abdomen can be effective. And then as they breathe out, they can count on exhalation. And as they breathe in and out, they can then progress to short phrases or sentences on exhalation. And this will improve also the ability to coordinate respiration and phonation. And the purposes can, be effective for in facilitating relaxation, improving again the breath support for speech, increasing control of the airflow, and increasing overall loudness with reducing stress. And the patients may become less fatigued, and they may be better optimized to communicate in those louder environments. Another technique that may be beneficial to some of these patients with dysphonia are laryngeal muscle tensions and relaxation exercises. Some of the problems, again, there are some repetition here, could be inclusive of hyperfunction, strained voice, and again, reduced breath support. So we tend to ask patients to participate in some head and neck rolls, shoulder shrugs, shoulder rolls, and isometric exercises. And this is to reduce overall tension. And again, some of these patients may have some tension harboring in the neck and shoulders just because of going through the stress of cancer treatments and a cancer diagnosis. So this is all things that can be seen during our sessions and can be helped with some of these exercises described. So, when a patient has an injury to the recurrent laryngeal nerve secondary to a lung cancer diagnosis, we know that there may be a potential for the patient to have inadequate vocal fold closure and glottic insufficiency. So, isometrics can be a intervention that can be implemented safely after an ENT assessment, where the patient is asked to phonate, typically a vowel sound, when pushing against an object or pulling up on a chair or pressing hands together. And then they want to phonate with gradual elimination of the pushing and pulling. So we want to safely increase vocal fold closure without causing any additional damage to the vocal folds. So it can be effective. Again, we do want to make sure that these patients at this point have been put under a laryngeal exam with an otolaryngologist. But again, it can be an effective tool to implement once we know it can safely be done. So vocal function exercises are another series of techniques that can be implemented with a patient that is demonstrating difficulty producing adequate voice secondary to lung cancer. So it's a series of systematic voice exercises to strengthen and rebalance the subsystems involved in voice production. So in many cases, we can describe or compare voice therapy to physical therapy, where there includes a warm up, stretching and contracting tasks, and then power exercises. So, as a warm up, the patient can be asked to sustain an E sound at a comfortable pitch and loudness. Then they could move into some stretching and contracting tasks, which could include performing pitch glides upward and downwards, a sustained vowel, tongue trills, and lip trills. For power exercises, patients can be asked to sustain E for as long as possible at a low, comfortable, and high pitches. So during the vocal function exercises, as speech pathologists and clinicians, we should be monitoring some techniques that the patients might be um, putting into place that could be actually working against them. For example, you want to monitor their posture. You want to make sure that the patients do avoid slumping or rigidity. Again, given their diagnosis of lung cancer, there may be a weakness in the diaphragm that we need to address, but we do want to maintain an upright posture at all times. Also, we want to monitor their breathing. So it does go hand in hand with that abdominal breathing that we had discussed earlier. So we want to make sure that we avoid the clavicular breathing. We want to monitor onset. So if a patient is hyperfunctioning or pushing their voice because it's strained and hard for them to phonate, we want to encourage the reduction and avoidance of a hard glottal attack. And all of these exercises do encourage practice. So these in particular, we may ask the patient to do twice a day, one at home, but really all of these techniques should be carried over and put into a home exercise program for it to be effective.
Good evening. My name is Rebecca Spurn. I'm a registered dietitian in the Department of Radiation Medicine. It's my pleasure to be with you here tonight. Tonight we'll be talking about the implications of nutrition and lung cancer. One of the biggest issues regarding all types of cancer patients is malnutrition. The exact parameters and definition of malnutrition is beyond the scope of our presentation tonight, but suffice it to say that ASPEN, which is the American Society for Parenteral and Enteral Nutrition, otherwise known as ASPEN, and AND, which is the Academy of Nutrition and Dietetics, together have formulated an exact definition based on certain parameters. What is considered malnutrition? And it applies to many, many different cancer patients. So malnutrition is something that we see throughout the whole spectrum of treatment, both before, during, and after cancer treatment. Many patients come in malnourished to their treatment, and many patients become malnourished throughout. And some of the results that can happen as a result of malnutrition is reduced absorption of drugs, reduced response to treatment, and slower recovery post-operations. So obviously malnutrition is something we want to be very aware of and something we want to address. And it's particularly relevant to lung cancer patients because for some reasons that we'll discuss later on, lung cancer patients are more prone to malnutrition than many other types of cancer patients. Cancer patients, almost 60% have lost weight at time of diagnosis. There are a lot of different reasons for this. One of them is that many patients have COPD, and many lung cancer patients have COPD, and COPD can lead to difficulty breathing, obviously. And as a result, many patients can have a lot of difficulty with eating sufficiently because it's hard to time the eating and the breathing and things like that. In addition, many patients are diagnosed at late stages of the lung cancer. So as a result, the cancer has already had a lot of effects on their body. In addition, patients who have cancer in general are in what we call a hypermetabolic state, which means that their bodies are working kind of on overdrive, like they're going 80 miles an hour. So as a result, their caloric needs are much higher. So especially because of the fact that we said that the lung cancer patients are often diagnosed at a late stage, we do see a lot of malnutrition with them. So weight loss has a very high impact on survival. Again, weight loss can occur along with malnutrition. It can occur throughout the entire continuum of cancer treatment, diagnosis, and so on. And weight loss can have a very high impact on survival. In In fact, weight loss greater than 5% is associated with a lower KPS, which is the Karnofsky Performance Score. It's a way of measuring how a patient's performance status. And also, if they have a lower, greater than 5% weight loss, it can also adversely affect a patient's quality of life. 5% weight loss is not that much. So many of our patients already have lost significant weight before they're diagnosed. In fact, weight loss, unintended weight loss, can often be something that spurs a patient to seek out medical attention. So many of them are already coming in very malnourished, which is why it's very important to try to identify it as early and quickly as possible. Related weight loss is very, very, very common. There are many nutrition impact symptoms that can come up during treatment. We all know about things like nausea and vomiting during chemo, but a patient who has lung cancer will often find that their swallowing gets painful because the area of the body that's being radiated during radiation is the part of the body that has the symptoms and side effects the most. So because the area of the body in lung cancer is close to the area of the swallowing, very often we see that patients who are getting treatment for lung cancer, it's not that they have problems with their swallowing function, and this is where the speech therapist obviously comes in, but it's not that they're having issues with their swallowing function, it's more that their swallowing becomes very painful as the food goes down the esophagus. So very often that will really affect their eating. It can be extremely painful. I've had patients say it feels like knives going down their esophagus. Um, Fatigue is a very common side effect of the radiation. And like I said before, chemo obviously can cause things like nausea, vomiting, constipation, diarrhea, taste changes, all these types of things depending on what the chemo agent is. So that can all lead to weight loss. In addition, like we said before, when a patient has cancer or any type of situation that's causing stress in the body, their body is in a hypermetabolic state and they have higher nutrient needs, which is almost like a catch-22 or a double-edged sword, because on one hand, the patient needs more calories, more protein than they normally do. But on the other hand, it's difficult for them to eat usually because of these symptoms and side effects that they're experiencing as a result of treatment. So that's why as much nutrition intervention as we can do to help them as much as possible. Seems to be an inverse association between BMI and lung cancer risk. The higher the BMI, the lower the lung cancer risk. Normally, we encourage trying to achieve and maintain a healthy body weight for cancer risk, but interestingly enough, with lung cancer, it's actually an inverse association. We still don't want to encourage people to gain weight in order to help with this issue. So we're going to still try to encourage weight maintenance, especially maintaining the lean muscle mass. And if a patient is losing weight, we want to try to encourage as much as we can within the confines of the treatment that they should either increase their weight or stabilize their weight. So we're not going to encourage weight gain, but it's just an interesting thing to know. So obviously, if someone's nutritionally compromised or malnourished, it's going to have a lot of impact on their functioning and their ability to go about their regular everyday lives. Fatigue is obviously going to make it much more difficult. If someone's feeling tired, they're not going to want to eat. They're not going to want to prepare food. They're not going to have as much energy and ability to care for themselves in general. They're going to not going to be able to move around as much. They have decreased ability to fight infection. They're going to have possibly longer hospital stays or unplanned hospitalizations. Their tolerance to treatment overall is just going to be worse. For example, we'll see patients who, if they're not eating as much, they're not feeling as good, they don't want to come to their treatments. It all becomes kind of a vicious cycle. So that's why, if a person's not getting the nourishment they need, I always explain to patients, it's like a car. A car needs gas in order to run. If they're not getting the nutrition and the fuel that they need, it's going to be hard for their body. I'll say to them, it's going to be hard for your body to do its normal work, but it's going to be especially hard for it to heal and recover. So that's why I often encourage patients to think of their nutrition as part of their treatment. It's almost like medication for them. And that's a message I give to them a lot. Effective study, not the largest study, a little over 100 patients, but they wanted to compare weight loss and weight stability to quality of life, some quality of life parameters. So the quality of life parameters they judged were fatigue and pain. obviously things that very much impact how a person is feeling overall. And they found that weight loss has an impact on different aspects of quality of life. So obviously, if a person's losing weight, they're not going to feel as good. They're going to feel tired because they're going to feel weak. The pain can be worse because their body just isn't as nourished and they can't fight as well. And this study was specifically regarding lung cancer patients. One of the strategies that we like to utilize is oral supplements. Um, I do encourage a food first approach as much as possible, but I am also very pragmatic and realistic. And I know that many of my patients just find it easier to just take something off the shelf, like an Intra Plus or a Boost Plus. We have lots of different samples in the office that we give patients. We have ideas for different kinds of shakes and different kinds of things to try. We'll talk about ways that a patient can increase their calories and the protein of the foods that they're already eating. For example, blending in peanut butter, adding dry milk powder, adding extra olive oil, cheese, and things like that. I give recipes for homemade smoothies, especially if a patient is having that painful swallowing. Soft, smooth, liquidy things are a lot easier to tolerate. And like I said before, we'll also talk about commercial supplements. Oral supplementation, nutrition support is indicated. Enteral nutrition is also known as tube feeding. It's when nutrition is going either through the nose or directly into the stomach. Sometimes it goes into the jejunum. There's different types of modalities in which a feeding tube is placed. There are advantages to nutrition support via tube feeding compared to most of the advantages are actually compared to parenteral nutrition, which we'll talk a little bit more about on the next slide. But one of the things we like about tube feeding is that it utilizes the normal route of nutrition. We say if the gut works, use it. So we definitely want to use as much of the normal way of digestion as we can. There are definitely some contraindications to tube feedings if the GI tract is not functioning. That's one of them. But like I said, there's a lot of advantages to including decreased rate of infection. Parenteral nutrition is when nutrition goes directly into a vein. It can be done either peripherally through a peripheral vein like in the arm or a central vein, like usually near the neck. That's called total parenteral nutrition. Indications are like if there's a GI bleed, high output fistula or ostomy, if the gut is not functioning for certain reasons, if there's ischemia, bowel obstruction, things like that. If a patient isn't able to tolerate tube feedings or oral nutrition for any length of time, we might consider doing parenteral nutrition. But it does carry increased risk of infection. It's more expensive, and there are some other contraindications. Again, a little bit more beyond the scope of our talk tonight, but it's just good to be aware.
Thank you for that, Rebecca. Now let's move on to a patient case. Kristen.
So now I'd like to discuss an interesting patient that Dr. Silverman and I worked with together. She was an 81-year-old female with a history of metastatic breast cancer with bilateral pulmonary metastasis, and she was being treated with oral chemotherapy. She had initially been referred to our department by medical oncology due to concerns for aspiration. During her clinical swallow evaluation, the patient demonstrated severe dysphonia marked by reduced loudness, reduced phonation time, reduced pitch range, periods of aphonia, and reduced coordination of respiration and phonation. She also demonstrated increased tension during phonation. And while I was talking to her and getting some more feedback about what she was experiencing, she reported that she was experiencing more shortness of breath, more fatigue, especially toward the end of the day, and the shortness of breath was worsening with exertion. So I had made the recommendation for her to see Dr. Silverman because I was concerned with vocal cord immobility. We had performed a stroboscopy and a FEES together, and the findings included a right true vocal fold insufficiency. She was also aspirating thin fluids and had LPR. The recommendation was initially made to use right head rotation during deglutition of thin fluids. Dr. Silverman had also planned for an injection laryngoplasty and had suggested the patients start a course of voice and swallowing therapy. So we did perform voice therapy, which we focused on improving respiratory function, improved phonation, inclusive of phonation time and loudness, We also wanted to reduce the tension in her neck. We improved vocal cord adduction, and we also reduced hyperfunctioning. We discussed vocal hygiene, reflux precautions, diaphragmatic breathing, easy onset, and also relaxation and laryngeal massage. The laryngoplasty was performed as well. And during our next last follow-up visit with her, her aspiration had resolved. She was recommended to take a regular diet with thin liquids, and her phonation had significantly improved. She was able to speak to friends and family on the phone. She started to attend social events, and she is currently traveling to Florida with her husband for the winter. I also want to include that we did refer this patient to PM&R. And at that point, the physiatrist had also assessed the patient and recommended that she go for a course of physical therapy, which was also inclusive of some respiratory tasks, which I think also contributed to her success.
Thank you all for your time in joining us this evening. Please note that to refer a patient to our program, you can email us at cancerrehab@northwell.edu or contact us at 833-480-0538. Have a great evening, all.